Okay, good morning and welcome to Medical Grand Rounds. It's an interesting time with COVID-19. I don't have a formal presentation for that today. I showed you some statistics last week that showed the numbers going up. And indeed, the numbers in the community have continued to go up. We are clearly in the second surge. Not up to the point yet that we are stopping any elective surgeries and so on, but people are preparing for that. On the good news front, we have moved into the new building, which is gorgeous. For those of you who have not had a chance to walk in there, it's quite a place. So the ICU and the mat unit are now together on the 5th floor. The ICU on one half of the unit and then extending into, we're not calling it mat anymore, it's officially the step down unit on the other side. They are busy. They have a significant number of patients. When I talked to them yesterday, they had 10 COVID-19 patients in the ICU. The 5500 floor, which had all our inpatient oncology patients, has also moved. So a lot of this is happening in the background. So far, so good. Everything is going well. Our grand rounds today is a Clinicopathological Conference. So I want to thank both Dr. Jadhav and Dr. Gupta, who helped come up with this case and orchestrate it. And most of all, Dr. Quwatli, who agreed to put himself out there and discuss it. I don't know how many people know Dr. Quwatli. He's been in our system for a decade at this point. He did his residency at Unity Hospital, was a practicing internist in town until last year, since when he's joined the hospitalist team at Unity Hospital. So without further ado, I'm going to switch to Dr. Nagesh Jadhav. Dr. Jadhav, you can put up your PowerPoint while we're talking. And Dr. Jadhav is going to present the case. Go for it.
Yeah. Hi, everyone. My name is Nagesh Jadhav. I'm one of the hospitalists here at Rochester General Hospital. Today, I'm going to present a case of a fever of unknown origin. So the history of present illness on this patient. The patient, was a 40-year-old male who has been having fatigue, subjective fevers, and night sweats for a 2-week duration. And the symptoms, and the patient's case, happened, in February 2019. I want to make it, explicit because this was pre-COVID, era. So the patient's symptoms started initially with body aches, night sweats, and subjective fever. 4 days after the onset of his body aches, night sweats, and subjective fever, patient started having dry cough. Now, the fever, the way patient explained the fever was, it was low-grade fever, 100 to 100.8 Fahrenheit. It would happen evening and night and followed by drenching sweats. Patient would say that every night he has to change his clothes because he would sweat profusely after having fever. He also reported having remarkable fatigue. Patient was an active person, and he said at the end of the day, he would feel so fatigued. The way patient reported it, it was that one time he was so fatigued at 3 o'clock in the afternoon, he was driving home and he wanted to pull over and take a nap, in his car. Patient also reported a backache, and he felt the backache was in lumbar area. At rest he would not have any pain, but he would bend down, he would have a discomfort in his back, and he felt that this pain happened because of some work related injury. He did not have any tingling numbness in his lower extremities. He did not have any focal weakness, no difficulty walking, no urinary or fecal incontinence or retention. His cough was intermittent, dry mostly, and very mild. In a day he would cough 2 or 3 times at the most initially. So his symptom continued for 7 days, and at that time the patient got concerned. So he called his PCP's office, and he was evaluated over the phone and started on Tamiflu. A flu swab was not obtained at that time because flu was endemic in Rochester region, and then it was thought to that highly likely. So he was started on Tamiflu. On Tamiflu, his fever and fatigue and night sweats continued. On day 9 of illness, the patient visited an urgent care. At that time, a chest X-ray was done, which was clear, and patient was started on azithromycin for bronchitis. At this point, patient started having a mild headache, and he felt that this was related to Tamiflu, and he stopped taking Tamiflu. On day 11, as the patient's symptom continued, he visited emergency room. He was afebrile at that time. His blood pressure was 110 by 70, respiratory rate was 16, and heart rate was around 108. He received IV fluids, blood cultures were obtained, a chest X-ray was again repeated, which was clear, and patient was started on doxycycline or cefoperoxime at this time. As patient's symptoms continued, he decided to see an infectious disease specialist at this point. Now, patient was a physician. This is what this account is what he informed the infectious disease specialist. He recently took care of a patient who was a renal transplant patient who had a CMV colitis, and he reported exposure to this patient. He also reported a common cold 4 weeks before onset of his current illness, which required him to take 2 days off from the work. He also reported wife and his child had a common cold 1 week before, and his child went to a daycare. Currently, both his wife and child were in good health. His past medical history was a history of childhood asthma and also seasonal allergies. He arrived in USA from India in 2003. He, as far as he knew, he had a PPD positive in the past as well in India. However, in US in 2006, his PPD came back also was positive. He received BCG vaccine as a child, and he received incomplete course of INH in India. He also has a history of Helicobacter pylori infection in 2017 and completed a treatment, and he had a subsequent negative stool antigen test. He was also diagnosed with liver hemangiomas, which were confirmed by MRI abdomen in 2017. He also had an endoscopy and colonoscopy, which was unremarkable in 2017 when he had dyspepsia. He had a past surgical history. He had an appendectomy 20 years ago. Family history: his mother, was alive and well. She had diabetes and type 2 diabetes and hypertension. Father was alive. He had a history of diabetes, hypertension, stage 3 CKD, and his father, who was a physician, also had a pulmonary TB as a child. Sister, he had 3 sisters. First sister, was alive and well, and had a history of hypothyroidism. Second sister had a history of pulmonary tuberculosis. But when she was diagnosed with pulmonary tuberculosis, she was a chest physician, and when she was diagnosed with pulmonary tuberculosis, patient did not have any contact with her. Third sister was in good health, no medical issues. His paternal grandfather had Alzheimer's dementia history. He was not allergic to any medication, and currently he was taking doxycycline and cefoperoxime. Social history, he was sexually active in a monogamous relationship with his wife. No smoking history. No illicit drug use. He drank alcohol occasionally. And he was a physician by occupation. The review of system, there was no loss of appetite or weight, no chest pain, no shortness of breath, no vision changes, hearing loss or tinnitus, no toothache, difficulty swallowing or neck pain, no abdominal pain, no nausea, vomiting or diarrhea, no urinary symptoms, no rash, no joint swelling or joint pain. On physical examination, when he visited the infectious disease specialist, his blood pressure was normal. He was tachycardic, 107. His temperature was 97.6 Fahrenheit. His weight was approximately 130 pounds. And this visit was 9 o'clock in the morning. He didn't have fever at that time. He was well appearing male, and he was having occasional dry cough. He had no cervical, axillary, inguinal, or epitrochlear lymphadenopathy. Neck was supple. Thyroid, on examination, was non-tender. His dentition was excellent. Lungs were clear. No murmur. Abdomen was soft, non-tender. No hepatosplenomegaly. GU exam was essentially normal, and all the exam was essentially normal. His labs test from his first visit to the emergency room, which was 3 days before he visited the infectious disease physician, showed mild anemia, 12.6. MCV was normal, but normal white blood cell count, and the differential was normal. His basic metabolic panel at that time was normal, and his glucose was slightly elevated, but this was post a meal, 10 o'clock in the morning. And he also had AST and ALT, which were mildly elevation, but bilirubin, and rest of the LFTs were normal. He had an atypical viral panel done at that time, and which was essentially unremarkable. Urine analysis was also unremarkable, and this was his chest X-ray, which was essentially clear, no focal infiltrate or evidence of lymphadenopathy. His results when he saw the infectious disease doctor that day actually showed that he is no longer anemic, so most likely the anemia was from the IV fluids. And his this time 3 days later, his AST and ALT had worsened, and he now also had an elevated ALK phos. His IgG, CMV IgG came back positive. However, CMV IgM antibody was below the normal abnormal cutoff. His CRP was quite elevated, and his also was his ESR, which was at 83. He had a monospot test done, which was negative. He had an HIV test, which was done, which was negative. He had 2 sets of blood cultures that were obtained and did not show any growth. And microbiology was asked to keep these blood cultures for 2 weeks and keep them incubated. He had a liver ultrasound done, which showed that stable hepatic angiomas, hemangiomas, biliary ductal, no biliary ductal dilatation, and no hepatosplenomegaly. At this time, a few diagnostic tests were performed, and I would hand over to Dr. Quwatli to take us from here.
Can I ask you a question here?
Sure.
Any recent travel history?
No recent travel history.
All right. So I'm gonna share my screen. Oh. So thank you for for giving me this chance to be part of RGH Grand Round. Um, so what I will do, I would take the important part of the history and go over it, and like I will like show how was my thought process, and how did I narrow my diagnosis, even though like still I have differential at the end, and what were my thoughts, um, and go from there. And maybe we can talk about something relevant to the case, and if we have time, and discuss it. So though I summarize here in this slide like the most important in the history. So he is like middle-aged male, because some infections like some diseases in general like has a age pattern, like autoimmune diseases like for per se like lupus or rheumatoid arthritis. They are more common in women, and ankylosing spondylitis is more common in men. Age also like helps, maybe not a lot in infections, even though like some infections can like happen in younger age, like mononucleosis, CMV, and Epstein-Barr virus. Um, the onset 2 weeks ago, that's tell me like it's more like infection than autoimmune. Autoimmune would be like over a longer period of time. Lymphoma also, like I think the presentation would be like the fatigue and the fever and the night sweats, will be like at least over like a month or 2 or 3, if you like, will be like subacute or like presentation. Fatigue at the end of the day, fatigue is one of the symptoms, like you find it in everywhere, like a lot of infectious diseases, autoimmune, malignancies. So fatigue is like, I would say that's non-specific. It's important, but non-specific to guide you where you're going. Body ache, the same. The fever is important, of course. It is subjective here, even though in this case I don't suspect like any factitious fever. We see factitious fever more in healthcare workers, but in this case I doubt, because the patient is coming with night sweats, fatigue, high SID rate. So the SID rate is not like a so there's something going on here. It was low grade. Between high grade and low grade, that's also like it could help a little bit in per se, if the patient like having bacteremia, let's say like from pneumonia. I mean, the patient would be like coming with high fever, and he would be like like really sick. The fever, it was mentioned that not associated with rigors. So I did stop at this, and I was like asking myself, we frequently mentions like fever associated with chills or not with chills. Is that like really important or no? I did like a lot of search about that, and there's like a few slides later we'll talk about this. It was responding to antibiotics, night sweats. Night sweats also, I'm gonna go over differential diagnosis with the night sweats, but like I would say most likely like TB, malaria, and lymphoma. And also like the night sweats may come after like breaking down the fever, if the patient like having evening fever and then he's taking the antibiotics, so he will break down in sweats. Dry cough started in day 4. The patient has 2 chest x-ray, they are negative, so he doesn't have pneumonia. His lungs exam were like clear. It doesn't seem to be like bronchitis. This like make me think again like about I start to think about sarcoidosis, about about TB again here in this case. So I'll move to the next slide. At the end, mentioned that the patient has back pain and onset like 2 weeks. Back pain is very, very common, and you see that a lot in the primary care setting. And even I thought it's only in the primary care. I was surprised when I became in the hospital, like hospitalist. Patients, they come to the hospital because back pain to the ED uncontrolled, and we admit them, physical therapy, and we go from there. Most of the causes of the back pain are musculoskeletal and improves on its own, and you know, very rare when you see a back pain, especially in the office, like when the patient has red flag, and you will know right away this patient needs MRI right now or go to the ED. So this back pain in this case, you know, I wasn't sure, is it like really important or just like, you know, one of the incidental finding? It says it is positional, like with deflection, and it looks like it's localized. So that's make me also like think about something local in this area if I want to put it in the context of this case. So no red flags, the onset like 2 weeks, like I would say that's still like acute, less than 4 weeks. Those information here, like on day 7, he took Tamiflu, he did not respond, he stopped the Tamiflu because of the headache. So it's, and he had the flu PCR and it was negative. In day 9, he went to urgent care, another, you know, negative chest X-ray. He was giving azithromycin. And then day 11, another negative chest X-ray and 2 antibiotics, and he did not respond. So basically here, we're not talking about like, you know, a typical or a typical pneumonia or like a typical bacterial infection that will respond. In my opinion, maybe we not have to start antibiotic in this case and just like wait and do more testing. So he was sent to the ID clinic from here, and with the social history physician, you know, that's giving him like this, give me like, you know, that the patient has has high risk of certain infections because of the exposure. So you know, and he came in from India, so he was definitely exposed to TB because his dad has history when he was a child. His sister had active TB, but he wasn't with her at that time. But that tells me like he came in from like, you know, an area there is a high incidence of TB, and he is exposed. I'm sure like, you know, some of his rotations were like, you know, in the pulmonary department where he took care of TB cases. So it's possible that he has latent TB that got activated. So that, you know, physicians were exposed to like hepatitis, especially if there is like, you know, any exposure to blood products or needles. You know, we're exposed to flu from our patients, so any like respiratory viruses or COVID-19 now. So it was mentioned that 4 weeks prior he had took care of a patient with CMV colitis. Also, I did some search. I mean, his CMV IgG was positive, which is like, you know, not surprising because most of us we got exposed to the virus, and you know, either we were asymptomatic or mild symptoms, and then we improved. And that's like, you know, what happened in most patients with who they are immunocompetent. So again, I mean, it could cause like fever and systematic symptoms like body ache. It could get into very serious infection. That's very rare though. Mononucleosis from CMV, again, that's what I said, like from Epstein-Barr virus, you will have like lymphadenopathy. And in both cases, in mononucleosis from CMV and Epstein-Barr, you will see like a lymphocytosis more than 50%, and you will see a typical lymphocyte in the blood smear. There was no blood smear done here, but like he has a normal lymphocyte count. His wife and child, they had a common cold a week prior, but I think the husband, the patient, gave them the common cold because 3 weeks before he had the common cold. So I think he gave it to them. I don't believe that that's anything to do with this. So yeah, so he had viral illness 4 weeks before, and he improved with supportive treatment. At that time, the fever was little high grade 103. With common cold, generally the fever will be like, you know, low grade, but still it's not impossible. Born in India, this will give me like a hint about latent TB. Um, 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 there's no recent travel. If I, you know, if the patient like went to India recently and came and he has those like bad, you know, maybe not low grade, high grade fever and chills, I will think about malaria. So positive BPD test since 2006. And that's, you know, was it negative prior to that? Is it like converted to positive? That's, I don't know. Is it like done before or never done before? He got the BCG as a child, and that's could give him like a false positive PBD test. And we don't know if he was treated for latent TB or not. The patient is not sure. Again, the family history of the TB, we spoke about that. I don't believe the H. pylori infection has anything to do in this case, or the liver hemangioma, those like, you know, something just in the history. You know, seasonal allergies doesn't cause, like, very rare one for allergies to cause, I mean, fever, unless it's like severe and it's going to be low grade. He doesn't have wheezing on exam. He's out of his asthma. Appendectomy 20 years ago. He doesn't have any symptoms to the GI tract. And his family history, what I took from his family history, you know, sister has hypothyroidism, and she has Hashimoto's thyroiditis. Sometimes, you know, you may get fatigue, little tachycardia, and he has an exam, low grade fever, and feeling tired and like very wiped out at the end of the day because of the equivalence thyroiditis, and this is like post-viral, and the patient has viral, and he had viral infection before. So I thought about that, but in this case, and he will have high SID rate. We don't have TSH, and it's worth doing it. But in this case, what doesn't go with this diagnosis is the patient doesn't have pain in his thyroid gland, and it's not tender on exam. So that's like a little bit, you know, I put it in the bottom of my differential. He did not respond to antibiotics, so that's telling me like either viral or that bacteria is not responding to those particular antibiotic, like special type of bacteria, or like, you know, autoimmune disease. You know, there's no any symptoms like, you know, to guide me toward like STD, and his HIV was negative. His weight is 130 pounds, but he's like he's thin to start with, but like he is not losing weight. His appetite is good. With lymphoma or even TB or you know, I would expect like the patient to start having like some, you know, decreased appetite or weight loss. Again, there's no nickname to suggest for any thyroiditis. He has no arthralgia and no rash, and that's important for, like, you know, autoimmune disease and autoimmune arthritis, because most of the people, they can, you know, they have like joint pain and rash and lupus. So our patient doesn't have these. What I took from the physical exam, you know, he was little tachycardic, and that's, you know, even though he wasn't febrile when he came in. So, and little anemic, little tachycardic. He wasn't febrile when he came in. He looked tired. Other than that, lung exam was good, and no rash. Thyroid is not tender. So, and there is no lymph nodes. Like, you know, one of my differential in the beginning, like, was when I read this case, I said, oh, night sweats and fever. He has those like few symptoms. This patient has lymphoma, but then the patient doesn't have any lymphadenopathy, and his chest X-ray doesn't have any hilar adenopathy. So, so still possible, but also I made it like lower in my differential after I saw the exam. His lab, like, you know, mild anemia, you can see that with any you know, infection or autoimmune disease, malignancies. mild elevation in liver enzymes. And, with this mild elevation in liver enzymes, I would ask for a hepatic viral panel. I think that's important here. IgG positive of CMV, that means like he was exposed before. His IgM is negative. ANA negative. ANA, I think, it gives us a guidance for autoimmune diseases, but it is a lot of time it's confusing because it's not non-specific, and it may, be positive in certain infections. High CRP and ESR, you can see that in infection, malignancy, autoimmunes. We'll talk about that a little bit if we have time. So monospot negative, HIV, blood culture negative. Blood culture, sometimes you need to re-incubate more because some kind of bacteria, they don't grow up in the culture like soon. I thought about brucellosis. Our patient did not have any recent travel. It's rare in US, and he doesn't have contact with animals. And he has negative viral panels. So again, all right. So, initially also I asked myself, is that like fever of unknown origin? And it looks like, yes, the patient presented within 2 weeks, but then throughout, like, the workup, it has been like more than 3 weeks, and he wasn't in the hospital, but he was like kind of getting like a lot of work up. So I would consider him definitely fever of unknown origin. Our body temperature tend to be little higher in the evening, and there's like normal variance like a degree. So fever in the evening always, like, it's more like we see more like high temperature or fever in the evening than in the morning, because our body, like, tend to be a little bit higher in the evening. That's one. Number two, we pay more attention to the fever in the evening because we are busy, like, during the day, in the morning. I'm not gonna say again, I spoke about, like, causes of fever, but I would add medications can cause fever. Our patient did not take any medications before that. Exposure to heat. So he wasn't exposed to heat. I don't know if he lives in Rochester or not, but like there's no like exposure to the heat. Some immunization can cause fever and vaccines. So fever of unknown origin, high fever, more than 38.3 on several occasions, more than 3 weeks, and uncertain diagnosis after 1 week of study in the hospital. Our patient had a lot of workup, so I would consider him fever of unknown origin. Detailed history, detailed physical exam, reassessing the patient frequently, because sometimes, like, you don't pay attention like to a certain lymphadenopathy that you found it later, or so it's always helpful. Again, travel history is very, very important. Exposure to animals, if the patient is suppressed or no in the drug history, and they were all like in the history, and if there's any localizing symptoms. Our patient had like most of the blood tests that has to be ordered for fever of unknown origin, and the blood cultures as well, and so far unrevealing. And again, as I said, with the high liver enzymes, I would suggest a hepatitis A, B, and C serologies. With fever of unknown origin, if you see any signs or symptoms point to a particular organ system, then you can be specific to that organ system. This slide basically about the same. At the end, we added here, like, we can do again the PPD test again, or the interferon gamma release assay. We'll talk about that later if we have time. Serum protein electrophoresis and CAT scan of the abdomen and the chest, we can add those with fever of unknown origin. So, for CRP and ESR, they are not specific, and you can find them like in malignancy, infections, autoimmune. So, but at least a normal ESR or CRP, tells us like a significant inflammatory process or whatever is absent. There's some expectations. You can see like patient with temporal arteritis with normal ESR. That's rare, but you can see. Procal, it is not recommended to check procalcitonin for fever of unknown origin evaluation. If you suspect, like, is again, like, if the primary evaluation or workup suggests appropriate site for biopsy, then you have go ahead and do the biopsy. Those about the CAT scan of the abdomen and the chest and the pelvis, definitely you can obtain them after all this negative workup. Now again, like fever without chills, chills without fever, I don't think that's anything like very important in the history. Chills is just like involuntary muscle contractions. It's like a physiologic response for the body when there's a sudden lowering in the body temperature. It can be confused with the seizures in children. That's something for pediatrician. In malaria, I thought about malaria in this case, but like I did like a lot of search, and they said in malaria, patient will have really bad chills. So our patient don't have chills and no recent nerve history. Can you have chills without fever? Yeah, you can. Panic attack, malaria, chills before the fever, hypoglycemia, anemia, hypothyroidism. Living in Rochester, you can have chills always. Sweating. So night sweats. I think that's important part of our patient history. So again, infections, TB, HIV, bacterial or parasitic infections, brucellosis, malaria, and some other parasitic infections, malignancies, lymphomas, and in lymphomas tend to be like at night. Some medications can cause diaphoresis or sweating. Our patient wasn't on any of these medications. Some endocrine causes. Again, I thought about hyperthyroidism in this case, post-viral. Some neurological problem can cause night sweats, and in the appropriate clinical context. And I don't think that's the case in our patient. Fatigue, I'm not gonna spend much time on this. Fatigue is very, very common, and almost like you see that a lot, especially for women, females, when they visit the primary care office. Like almost the fatigue is, it's kind of like permanent in the review of system. So too many causes for fatigue, and really it costs the health system a lot of money. Could be acute, subacute, or chronic. Of course, like acute fatigue, like in our patient, it's you have to think about medical conditions, a lot of causes. I'm not gonna go over all of them. Low back pain, I want to just spend little time about this in our patient. So again, I'm not gonna repeat again. Back pain is very common. Most likely it is not significant. You see that a lot of the PCP office, the patient almost like recover very well with just like conservative management. When there's red flags, you have to pay attention because could be like serious etiologies. And I will show you a table that can summarize all these. So here, mechanical low back pain, those are it could be still serious, even the mechanical, like especially if there's like fracture or spinal cord compression. So could be that's the case in our patient, musculoskeletal from strain, as he said at work, but also could be serious because he have a high SID rate, he has fever, and localized pain in his lower back. So here, I kind of like I suspected discitis, could be like septic or maybe paraspinal abscess. Ankylosing spondylitis, I thought about it a little bit in this patient, but like the back pain would be in the morning with morning stiffness, and it improves with the physical activity and throughout the day. Of course, there's other cases where the patient could have low back pain, prostatitis. That's very common, and we see that in the primary care setting. But the patient doesn't have any urological symptoms. Malignancy is always should be in the back of our head when patient has like back pain that doesn't respond. conservative management. And here in this, that's from up to date. And just I want to show you here, like the patient has back pain less than 4 to 6 weeks. Our patient had the back pain for 2 weeks, and he doesn't have any red flags. See, he doesn't have any red flags. Okay, so and no cancer history. He doesn't have like high risk for cancer, but he has high SID rate, and I think images in this case is appropriate with having. It mentioned here objective fever. I do believe this patient has fever. So with fever and high SID rate, I think at least you can do plain images, and then MRI. I lean more to have MRI right away because the plain X-ray is not specific, but still we can do it like before doing the MRI of the lumbar spine. Do I have still little time or?
I think you're almost out, so maybe try to wrap it up so we can.
So the PBD test or the T-spot. These days we do like I think the T-spot is better than the PBD test. It has some advantages over the PBD test. Some of these advantages, it doesn't give false positive results because of prior BCG vaccination. That's very important. I want to to point to this. And then back to my patient: TB, lymphoma, sarcoidosis, malaria, thyroiditis, prostatitis, ankylosing spondylitis. Now, initially I did not know about the travel, but maybe blood smear, TSH, T-spot, and MRI lumbar spine. I hate to lose money, but I was told that that's the rule of the game. I have to put my money in one diagnosis. I will order T-spot and MRI lumbar spine. And thank you.
So that's great. Nice discussion. Thank you. And with that, I'm going to invite our surprise guest specialist to tell us the answer.
Oh, super. Okay. Well, we'll go quickly here. Dr. Quwatli did a great job. And he talked about the FUO. This patient was a physician. We know about the common cold, and this physician actually is somebody we know. He just presented the case, Dr. Jadov. And this is his usual appearance, smiling, pleasant personality. But when he was sick and had this fever for 2 weeks going on, and feeling fatigued, feeling like he needed to sleep in the car, he was worried about it. And he knew there was some sinister diagnosis possible. Now, he didn't look this up on the internet, but like any good physician, he did wonder about what was happening. And particularly after seeing both his internist, Nisha Gupta, and Ed Walsh, and had the tachycardia. Well, tachycardia and fever, he looked up lots of articles and came across that subacute thyroiditis could be a possible cause of fever of unknown origin. Certainly something Dr. Quwatli appropriately mentioned, but Dr. Quwatli put it at the bottom of his list, as I would have also, because there was no neck pain, which is very unusual. But TSH and free T4 was added, and it was added to tests that were blood work that was done on February 25th. The tests were ordered on that blood work on the next day, and somehow didn't become available until Friday, March 1st. I'm not sure just what happened, but that's when I became involved and spoke with Dr. Jadov. And when I looked at these tests, I said, gee, I think thyroiditis is a very good possibility. Just looking at the thyroid level, because the T4 is elevated out of proportion to the T3. T3 normal goes up to about 180, free T4 up to 1.8. And if you look here a few days later, his free T4 was up to 3.7, T3 was about the same. And a T4 elevated out of proportion to T3 in a hyperthyroid individual, think thyroiditis, think thyroiditis. And of course, Dr. Quwatli didn't have any thyroid function tests because they hadn't been done until 2 weeks into the course. Now, we had one set of thyroid function tests from the past, 2016. Maybe that's his baseline. Maybe Dr. Jadhav should have a free T4 of 1.2 and a TSH of 1.99. Dr. Quwatli said that he wondered about thyroiditis, wondering about a post-viral thyroiditis, but put it at the bottom of his list, again, because there was no neck pain. And I would have done the very same, because neck pain is the presenting symptom in almost all of these cases. And the thyroid tenderness isn't subtle. In most cases, it's severe. People are moving their neck back and forth or neck up and down. And some people, I saw a couple people who had such neck pain, they really couldn't walk. They were in wheelchairs, not because they couldn't walk, but because the walking upset their pain. And usually it's this triad of a very painful thyroid, fever, low grade usually, and inflammatory markers. And his SED rate actually peaked at 113. And he didn't have a very painful thyroid. He had maybe a mildly painful one we'll get into. So we'll go back to his flow sheet. Here's his free T4 out of proportion to his T3, a very low TSH that went lower, anti-TPO antibodies, which are the best test for autoimmune thyroid disease, were below the level of detectability, and anti-thyroglobulin antibodies, the lower limit of detection, I mean, it's considered positive, it's of above 60. His was on the high side, but this was done exactly 2 weeks after his initial presentation. So when I got involved on March 1st, when these tests came back, that was a Friday, and I spoke to Dr. Yadav and I said, you know, this sounds like thyroiditis to me, but it's atypical because it's not tender. He'd already started on naproxen, 220 milligrams, taking 2 tablets twice a day. I told him I'd see him over the weekend, but he said, you know, I think I'm a little better just starting the naproxen. This was on Saturday, March 2nd. He did definitely feel a little better. He said he'd had fever the night before, but very slight, no diaphoresis. And Sunday, March 3rd, I don't know, he's indicated he was much better, 40% back to normal. And I plan to see him on Monday morning, March 4th, which I did. And thinking he had thyroiditis at that point, based on what we knew, I perhaps examined his thyroid a little more intensely, and he had mild, and I would say mild thyroid tenderness. But as endocrinologists like to do, they have patients drink some water and feel their thyroid. And I always have people drink the water and get their neck hyperextended and then swallow. And as soon as he did that, he did a double take. His neck was tender. We talked about the thyroid uptake, which we scheduled, and it confirmed thyroiditis with a 6-hour and a 24-hour uptake that was well below 1%. So this came back on March 6th, a Wednesday. And I talked to Dr. Jadhav about this, and he said, well, I was much better over the weekend. I'm still on the naproxen, but the fever's returned, not as high. I'm not really having drenching sweats, maybe a little sweats. I'm not kind of feeling as well. I'd already talked to him about the possibility of prednisone, and like the good doctor he is, he'd read about it, and he said, I think that's a good idea. And we started on a dose of 10 milligrams in the morning, 10 in the afternoon, 20 milligrams in the evening, total of 40 a day. And within 36 to 48 hours, if this post-viral subacute thyroiditis is a diagnosis, you can take it to the bank that the patient's going to be much better. And when I talked to him on Friday, he said, wow, I am so much better. No fever, I'm not as tired. Maybe I'm not tired at all. My neck tenderness is entirely gone. So this thyroid uptake was important because if you have Graves' disease, or in this case, a toxic nodule, you have an increased uptake. Again, Dr. Jadav's was less than 1%. A typical Graves will be 50 or 60%. Typical thyroid nodule might be 60 or 70%. But in thyroiditis, whether it's painful or mildly painful, like Dr. Jadav's, or whether it's not painful at all, like we see in postpartum thyroiditis, which we're not going to talk about today, but a common entity, a fairly common entity, occurring in about 5% of pregnancies, you don't see any, you can't do a scan, there's no uptake. This marker is just kind of where the thyroid gland would and should be. So thyroid toxicosis occurs with thyroiditis, and it's the inflammation damages thyroid follicles, and it results in unregulated release of T4 and T3. And the thyroid toxicosis persists until the stores of T4, T3, and thyroglobulin are exhausted. And usually that takes at least 3 to 8 weeks, and sometimes takes a longer time or a shorter time, depending upon the patient. And there's a relatively short euthyroid phase that follows, and then a hypothyroid phase that's occurring while the damaged thyroid follicles are recovering, and all the T4 and T3 has been released. So here's in character, here's the hyperthyroid phase, and it's not from the thyroid making more thyroid, but the inflammation releasing it in an unregulated way. You go through this transient euthyroid phase, and that's just because the T4 and T3 in the thyroid is petering out, and ultimately go into this hypothyroid phase, which here in this graph lasts 2 or 3 months, but sometimes can be 5 or 6 months, after which usually, not always, there is return to recovery and a euthyroid state, but many times the long term is that people become subthyroid. So here's back to our flow sheet. He started on prednisone the day we knew that his thyroid uptake was essentially zero. A week later, he was 70% of the way back to normal. The dose had been reduced. A week later, he's 85%, maybe 90. And as we talked more, he said maybe 95%. He was much, much better. Reduced to 5 milligrams of prednisone in the morning, 15 milligrams in the evening. He was sleeping less, and was still sleeping less a week later when he said, there's nothing wrong with me anymore. I'm 100%, I'm not tired at all. I feel maybe, if anything, a little more energetic, but I'm only sleeping 5 hours a night rather than my usual 7. And we see that after thyroiditis, and maybe it's because of the prednisone that's being utilized, and I really don't know. But you look at his other tests here. Here's February 11th, his first day of symptom. Here's March 19th, a month later, and his free T4 is 3.3, but 1 week later, it's 1.9. Now, we talked about a transient euthyroid phase. 1 week later, it's 1.2. And I talked to Dr. Jadav at this point, and I said, you know, as fast as this has gone, in the coming weeks, you're going to be hypothyroid. Well, I wasn't right at all, because he's remained with a normal T4. And you look at TSH, here, I mean, he's mostly in the 3s. Now, maybe that's a little high, because his baseline in 2016 was 1.99. Here he had a 5.37, and that is a little high. And I thought, well, we're going to see it 15, 20, and we're not going to go up any higher than that, because he's going to be subthyroid. But thus far, he hasn't. These last tests were done about 7 weeks ago. He's going to have a repeat test in a couple more weeks. And I'm happy to say he's back with his nice smile, his beautiful wife, and I think his little boy is about to give him a kiss. So with that, I'll give it back for any questions.
Thank you, Bob. Dr. Jadav, you want to make any comments since you were the case?
Yes, like, and I like, first of all, I'm thankful that this did not turn out something sinister and like something which like, I could recover from. But the whole experience for 2 weeks was scary. Like, and one thing I want to say that when I visited like, ED, one powerful statement that the ED nurse made, which like, I made me felt better, was that she said, we don't know like what's going on, but I hope you feel better and you recover from this. And people showing kindness and empathy, like, to me when like, I was scared, was quite powerful. And I thank Dr. Walsh, Dr. Heinig, and Dr. Gupta for their incredible care during that time.
Yeah, thank you. And Dr. Quwatli, congratulations. I think you got it. It was, without the neck pain, I think it's impossible to get this diagnosis, but you would have done the thyroid function, so you would have picked this up.
I thought that was a wonderful resume, yeah. Dr. Quwatli, of what you did.
Yeah.
And right on.
So I have one question. Mary Cohen says, I had a woman with acute thyroiditis after a flu shot. Is that something that's described?
Yeah, it is described. And it's been described after a flu shot. It's been described after influenza. There are a number of case reports with the COVID-19. And it's, and there's probably 200 case reports of various things following what usually seem to be a viral infection and also immunizations, not only with flu, but other.
Yeah. Well, thank you very much. We're just about out of time. This was a fantastic discussion. Thank you all. And have a nice Thanksgiving, safe Thanksgiving with your families. See you back at Grand Rounds in 2 weeks.